Hey everyone, this is Travis Elbert. I did my final research project on pneumothoraxes. I chose this topic because I've always found them interesting, and there's many ways to diagnose and treat these depending on which society or research paper that you choose from, and just wanted to take a little deeper dive into it. So, the pneumothorax is defined as a pathological collection of air within the pleural space outside of the lung parenchyma. They can be divided into traumatic or spontaneous. Spontaneous being there's no obvious inciting factor, traumatic being with an obvious history of trauma, typically resulting from either a MVA with rib fracture that can puncture the lung, or a penetrating wound such as a stab wound to the thorax or a gunshot wound. The spontaneous pneumothoraces can be divided into primary and secondary. Primary being there's no underlying lung disease, secondary being that the patient already has a diagnosis of COPD, some other form of bullous disease, or malignancy. And the two biggest risk factors of pneumothorax are smoking and being male. So for your history and physical exam, the patient will typically have been at rest for a spontaneous pneumothorax with a sudden onset of dyspnea and unilateral pleuritic pain. This occurs in about 90% of spontaneous pneumothoraces. Other possibilities include recent airplane travel or scuba diving. For a traumatic pneumothorax, there will be an obvious history of some traumatic event in the time period leading up to presentation. For the physical exam, you may appreciate tachycardia, decreased absent lung sounds on the affected side, and some anxiousness. Tracheal deviation, altered mental status, hypotension, and profound hypoxia are obviously all very ominous signs and can be seen in tension pneumothorax, which must be treated emergently. A patient can be considered stable if they have a pulse of between 60 and 120 beats per minute, systolic blood pressure of 90 to 180 over a diastolic blood pressure of 60 to 120, an O2 sat of greater than 89%, and can speak a full sentence. So after you've completed your thorough history and physical exam, you need some mode of diagnostic imaging to secure the diagnosis of a pneumothorax. Historically, the upright chest x-ray has been the go-to imaging modality to secure the diagnosis of pneumothorax. However, in one meta-analysis, the chest x-ray only had a sensitivity of 46%. It was 100% specific, but it's not reasonable to rely on a modality that misses over half the diagnoses as compared to the gold standard CT. The identifying a pneumothorax on chest x-ray is dependent upon seeing a pleural line. More recently, ultrasound has emerged as a valuable point of care imaging modality that has an impressive 87% sensitivity and 99% specificity. Diagnosis with the ultrasound can either be secured by a barcode appearance as seen on the slide versus a normal, looks more like a sand on the beach appearance in M mode, or if one can see air between the parietal and visceral pleura. As I said, the CT scan remains the gold standard of diagnosis and has the highest capabilities of evaluating the exact size of the pneumothorax. The treatment of pneumothorax is chiefly guided by the patient's presentation and the size of the pneumothorax. Stable patients with small pneumothoraxes can easily be managed conservatively without intervention. Unstable patients require invasive treatment. If tension pneumothorax is present, that first step should be immediate needle decompression followed by chest tube insertion. And according to the British Thoracic Society, needle aspiration can be attempted prior to chest tube drainage. However, that the American College of Chest Physicians recommends that if drainage is warranted, that chest tube drainage is first line. Stable patients with large pneumothoraxes are still recommended to receive invasive treatment by both societies, but there was one study conducted in France at a single center that showed that a one-way Heimlich valve pigtail catheter can be used with outpatient treatment with good outcomes. Patients that are seen in a medical setting for pneumothorax typically have extremely good outcomes, as it is a condition that, if it is necessary to treat with an intervention, can be done very rapidly with good success. However, every procedure has its risks, and complications are more prevalent with pneumothoraxes that require invasive treatment, with up to an 11% complication rate. These complications can include tension pneumothorax, empyema, hemothorax, and subcutaneous emphysema, whereas complication rates are virtually non-existent for conservative treatment. Along with complications, the recurrence rate with a year of follow-up in some series showed a rate of 17% recurrence with invasive treatment and only a 5% recurrence in conservative treatment. If a patient has multiple recurrent pneumothoraces, they may be a candidate for VATS, video-assisted thoracic surgery, and with that, the surgeon can elect to perform a pleurodesis, bulectomy, or lobectomy. And pleurodesis can be chemically achieved with the use of talc or other chemical, or mechanically achieved by using abrasives to promote adhesion. So these are my references, and in summary, the treatment and diagnosis of pneumothorax, like many other conditions, has been the subject of continuing to do something just because that's how it's always been done. I hope some of the data that I've presented, especially with the diagnosis with ultrasound versus chest x-ray, as well as the stressing the points on conservative treatment whenever viable option, can be employed in the clinical setting. However, it must be remembered that if a patient is unstable, that immediate intervention is a life-saving treatment with either needle decompression or chest tube drainage. Thank you for listening, and take care.